Great. Welcome. Hello. Maggie's so much shorter than me. We've got the table down at this weird angle. Can you hear me? I want to stand up straight, actually, but I have to read a thing. So welcome. Thank you all so much for joining us on your lunch break, and I can see lots of folks from different areas, so that's exciting.
Code white for our level 1 emergency ASU. Code white for our level 1 emergency ASU. Code white for our level 1 emergency ASU.
So this is part of our What's New in Addiction Nursing series. So these public lectures are presented by nursing fellows currently going through the BCCSU Addiction Nursing Fellowship. My name is Emma. I'm a clinical nurse educator for substance use here at St. Paul's. I'm the director of the Addiction Nursing Fellowship. So I'm going to introduce Maggie Tong. This is everyone's favorite part. They get to hear their little bio read out loud, and then she'll move on to her talk today. So Maggie's a registered nurse originally from Edmonton, Alberta. She grew an insatiable interest in learning about addiction and mental health, which led her to move to Vancouver. Here she began working in anything and everything mental health related, inpatient detox, outpatient clinics, day programs, outreach, and most recently probation services. She continues her learning as a current BC Centre on Substance Use Addiction Nursing Fellow, and can't believe she has to survive giving this talk today. So this talk for the fellow often feels like sort of like the biggest piece they do, because this is a big deal to give a public lecture. So she has some interesting things in store for us today. And yeah, join me in welcoming Maggie for her talk. Well, let's talk substance use and depression in health professionals.
Thank you. Let me just. Everybody can hear okay? Back up and back, yep. Thanks for coming. It means a lot. So let's talk. So anybody know where I tried to make it a catchy title. Anybody have any idea where it came from? Yay, Belle, let's talk. Yes. So let's talk. I want to continue that conversation. We're going to be talking about substance use and depression in health professionals. We got a really cool room, so if you guys have questions, you guys see those like alien looking UFO things on the seats in front? If you do have a question, just kind of touch it and it'll kind of glow red and you can talk into it so I can hear you, because I struggle with that a little bit. Okay, so I'm here to actually present to you guys a really revolutionary, life-changing idea. Obviously, before I tell you that, I'm going to respectfully acknowledge that I'm a humble guest on the unceded traditional territories of the Musqueam, Tsleil-Waututh, and Squamish nations. And let's get into it. So Bell, let's talk. Yes, I have no affiliation with Bell, but they raised $7 million last week for mental health programs and things like that, which is fabulous. I like to kind of get to know you a little bit in my talk. So I'm going to go a little millennial on you. So who's got one of these? Who's got a phone? Take out your phone. I know most people are like, put your phone away. No, take it out, please. I'd like us to get a little interactive in here. So please, if you have a web browser on your phone, you have reception, hopefully you do, please go to this here website and hopefully you make it there. You know, you should see something that looks a little like this. Anybody see that? Let me know if you've got it. Did we get it? Oh, fabulous. So I'm gonna count. I get this right here. I can see, but unfortunately I can't like put it up just for technical things that I don't want to risk. So I'm gonna count to 3, and I want everybody to vote on how they're feeling today. Okay, ready? Everybody ready? All right. 1, 2, 3. Oh, you guys are feeling pretty darn good today. 4 of you are here for the food. I see you. Over there up in the back, my team. I see you. Some are not great, and it keeps changing. You know, it's cool. Some of you guys are feeling stressed out. And I just want to let you guys know it'll be interactive today, and I wanted to make it a safe space to talk about things that I'll be covering. So please know in this kind of link up here that I have, I will be opening some polls where you could answer anonymously. I don't know who asks questions and things like that. And the bottom of your phone at the kind of the corner, you'll also see that there is a Q&A section. At any point, if you have a question you want to ask, but you don't want to ask it out loud, I will see it if you put it in there. So let's have some fun today. Okay, I want to start off with a case study because what lecture is a lecture without a case study? So we have to start with a case study. So here's patient X. She's a 26-year-old female. Come to the clinic for worsening depressed mood for the last 3 years. And if you ask her, she'll say that it's getting worse within the year. Decreased appetite, not wanting to eat at all, fatigue, but sleeping 14 hours and finding you still can't get any energy. Started to miss work and started to think thoughts like, oh, well, anybody could do my job, so why should I go to my job? Things like this. Poor memory, difficulty concentrating, doing the most simple tasks in your everyday life. Loss of interest in writing, drawing, and music. So my question is, what do you guys think this person is struggling with? And you can just tell me. Yeah, depression. A few people said it. Thank you. Yes, depression. So we'll go back to the case study in a little bit, but I want to go through kind of depression. So 330 million people in this world struggle with depression. These are World Health Organization statistics. Okay, so when I say 330 million, I actually struggle with really big numbers because my wallet's small and I don't get to this point. But that being said, I don't know what that means. So I found a way to show you guys. So I went to the US Census Bureau website and they have a population clock. So this is a clock that counts down how many people are actually living in the United States. As of Super Bowl, February 3rd, when I was hurriedly finishing this presentation, there was 329 million people living in the United States, like recorded on statistics. So let's go back to that number. 330 million people struggle with depression. That is like the entire United States population struggling with depression, which is mind-blowing, I think. So I want to go back to my revolutionary idea that I said I'd tell you guys. So I have to do that. So, and it's this. Health professionals are people. Revolutionary. I know. And there's, you know what? There's no citing for this. I didn't see it in any literature or anything, but this is my idea. Health professionals are people. We're not superhuman. We can't work 16 hours a day, every day. We struggle with the same stuff that everybody else struggles with. So like depression, like substance use, like bipolar disorder, anxiety, we struggle with exactly the same stuff. And why would we struggle with that? Because we're people, okay? So gonna do a little activity here. How many of you guys have heard this from anybody? Anybody? Put up your hand if you heard this before from somebody or said it yourself. That's like everybody. Me too. I say it all the time. I'm just burnt out. Okay, how about this one? This one's, I think, a little bit more, might be more health professional centered, but how about this one? Oh, I just take some Benadryl or Gravol for sleep. Yeah, some of us. I've said that before, especially in nursing school. So what I want to do today is change the way we are thinking about things. So we hear these things all the time, especially the one about, oh, I'm just burnt out. But what happens when the conversation changes a bit? What if the conversation is different than what we're seeing? So I'll give you an example. What if I'm just burnt out means I'm just struggling with severe depression and those symptoms associated with it? What about I just need some opiates or benzos to get to sleep? So opiates being painkillers and benzos anti-anxiolytic for anxiety medication. So, all right, those of you that did get food, now's the time to fall asleep if you do want to take a food nap, but I'm going to be going into some stats. So, but my assumption here is that these stats are actually quite alarming, and my hope is that you'll actually stay up for it and realize that there's a lot going on. So looking at just Canadians as a whole, 1 in 5 Canadians experiences mental illness or an addiction problem. 1 in 5. And where these stats are from, actually, it's actually for people ages 15 and older. So we're not actually even capturing the adolescent population or youth population. 1 in 5. And that's all of us, all of us. So I want to talk about health professionals in particular and mental illness. So interestingly enough, Canadian nurses have 2 times the rate of depression than when you compare to regular working women in other professions. That's not okay. So what does that look like in percentage? So if the prevalence rate is about 5% for the general population of women working, nurses is 10%. And that's a Canadian study that's actually local. So I have a question now. So why? Why the higher rate of depression in nurses? That's what I want to know. So I'd like you guys to, if you wanna join anonymously, back to your little thingamabob. I'm just gonna open up the poll here. Let's go with me. Let's see. So you can enter your answers in and I will get them, but I will take it to the audience. Why do you guys think that nurses are struggling with depression doubly compared to everybody else? Anybody know? Yes. Shift work. Anybody else? Stress. Yeah. Let's see what I got here. Okay. So one of you guys said what they see at work, which I agree with. Lack of breaks, not taking a lunch break. Oh, there's too much happening on the unit. I can't go. Stress, overworked, demanding job. You see a lot of death or illness. Too many shifts, which I am also guilty for. Also, you'll see people that have problems, not necessarily well in that state. Somebody put doctors. Vicarious trauma, emotional labor. Yeah, I see burnout all over my list here. Yeah, stress. Let's talk about that a little more. And you guys are right, absolutely on the money. So what are we looking at here? So we'll start with the little red guy in the corner there who's like, yelling. So a lot of studies have shown that nurses do find that they get in contact with physical or verbal aggression, whether the client means it or not, but that's still something that happens on the job, as well as I'm sure doctors, social workers, OT, PT, whoever you are. Second picture there with the gentleman having some symptoms. And it's true, you guys are right. We see people who are ill a lot of the time. People don't usually come to health professionals when they're totally well, right? Sometimes they do, but we are seeing that. Then the constipated face on that side. It's stressful work environment. So having like a pressure cooker scenario where you are feeling like you have so much work that you won't get through it in the day, and when you leave at the end of the day, you're finding that you're still kind of wound up, feeling like you didn't get anything done. In particular for doctors, also nurses, huge responsibility, a feeling of responsibility. If you make a mistake, if you miss something, it's that constant stress of being a health professional that is a little more unique. The clock there for shift work, obviously if you're doing night shifts all the time, you might not be seeing your friends, you might not be seeing your family, because who else is up at 7 to 7 a.m.? It's not great. And it also contributes to lack of sleep deprivation, which, all in a whole, these things contribute to depression, but at the same time, we know already that people who already have depression are more at risk to develop substance use disorders. So I am going to get into that now, specifically for health professionals. And I want you guys to read this stat. 10 to 15% of health professionals will struggle with addiction in their lifetime. So you might be thinking, oh, nurses, doctors, hang on. This particular information was a big survey that included occupational therapy, PT, they included social workers. Any social workers in the room today? Do we have any? Yeah. So not on this slide, but there have been a lot of recent literature that suggests that social workers actually have 55.6% higher chance of death by suicide. And that's really interesting to me. So before you think, I'm not the health professional, it affects everybody. So 10 to 15%. I want to talk about addictions in more specific fashion. So I looked at a few studies out of the United States that looked at US surgeons, and this is what it suggests. surgeons in the US, and this is people who responded to the survey, and they did kind of a look of assessment questions for substance use disorder for alcohol, and 2 to 5 times the rate of the general population was misusing alcohol. So 2 to 5 times. So what does that look like in percentages? So, oh, sorry, it's actually, I have it here. 5% of the general population struggles with alcohol use disorder. And when you looked at strictly US surgeons, it went up to 15%. Now, that rate actually changed depending on where you worked in the United States, but basically as a whole, what we're seeing is that that's huge. Why are we having double the rate of that? What I'd like to note though, is that yes, we're struggling with alcoholism. We're struggling with a lot of things that the general public does. But what might surprise you is that the rate of substance use is actually not very different from the general public to health professionals themselves. It's actually, we struggle with it the same amount, and where it changes is what we're using. So I'd like to kind of focus on which one we're struggling with the most. And it seems like it's benzodiazepines and opiates. It seems that we, as health professionals, have a 5 times greater prevalence of using benzodiazepines and opiates compared to other substances like cannabis, tobacco, and alcohol. So we can look at some percentages here. For benzodiazepines, if you look at the general population in Canada, 0.2% versus 1%, which are health professionals. Now you're looking at that number and going 0.2, like that's not a lot. It's not a lot. So let me break it down for you. These stats are actually, they're Canadian stats. And when you look at the 0.2%, what I was looking at was only people who reported non-medicinal use of benzos and opiates. So you weren't prescribed it for any reason, it wasn't for pain, things like that, non-medicinal use. And these are people who self-reported. So it might be possible that somebody doesn't actually know that they might qualify for being in the criteria of having a substance use disorder, but they weren't captured here. So keep that in mind when you're looking at these numbers. And for opiates, same thing, it was like 5-fold. So here's my question. Why the high rates of benzos and opiates? Why are we going towards that and not reaching for other things? Like this is a significant area. So I'm going to open another poll for you guys if you want to join. And so if you want to add your responses, I will get them now. But I will take it to the audience. Anybody have any ideas why benzos and opiates are kind of the big struggle here? So easy availability. Yep. Yeah, like the substance itself. Yeah. Anybody else?
We think we can use them safely.
Yeah. Let me see what you guys kind of typed in here. Let's have a look. Okay, access. Everybody said like access here. Availability, I'm seeing that. Emotional pain, opiates and benzos soothe those. Pain control, because we're healthcare workers, we use our bodies quite a bit. It's numbing. You're right. Somebody said, well, people think it's okay to use these sedatives. Sleep. Remember, if we're already sleep deprived and you're telling me you've got a solution for that, I might be listening. So access. So also somebody put here, less internal stigma about meds versus street drugs. And I agree with that. So let's talk about the specific things that I did find. And these were mostly related to doctors and nurses, but it can apply to anyone that has access to a prescription pad, really. So number one, yes, access. That's one of the theories that's out there. One of the studies said that it wasn't actually doctors like prescribing things to themselves. It was you prescribe it to a friend, under your mom's name, under your dad's name, things like that. That makes it a little more dissociative. Another thing was just access of the actual substance on the unit. The medication cabinet's right there. We're always reaching for it, things like that. And the little guy in the corner again, stressful work environment is another theory. of why benzos and opiates are kind of the choice right now. So interestingly enough, there's a lot of other reasons that are here, and I kind of want to just talk about that. So a lot of doctors actually said that in surveys that were conducted, they said they didn't want to go get help because they didn't want to go see another doctor. Because what they found was that the doctor would be like, well, you're a doctor, what would you like to do about that? And at that point, you don't want that shared care for yourself. You're doing that all the time. So that was a barrier for that. Another thing is denial. We're really good at looking at, oh, DSM-5, here's the criteria. This meets the criteria, let's treat this. But the funny thing is we're really bad at seeing that in ourselves. So we'll talk about that. And I think a significant problem on why everything is worse, why these rates are the way they are, is we're not talking about it, right? So like, why? Why don't we talk about it, guys? Anybody have any idea? Why don't we talk about like depression in healthcare providers? Why don't we talk about the absolutely astronomical problem that we have with physician suicide right now? Yes, stigma. People think it's what comes with the job. Yeah, absolutely. I have an answer for that. Oh yeah, up in the back. Yeah, so we're expected to be superhuman, is what I'm hearing. So my answer to that is this. My revolutionary, life-changing idea. Why are we not talking about it? Because healthcare providers are people. So let's take that away. Let's say that you're not a health professional. Let's say that you're just anybody, right? And in any profession. Why wouldn't you tell your best friend that you're struggling with opiates? Shame, embarrassment, right? I heard those. Stigma. And also, why wouldn't I tell my friend I have depression and I'm really struggling with that? Yeah. Judgment. Yep. Yes. Yes. A sign of weakness. Yeah. You should be dealing with it on your own. Well, you're a doctor, you're a nurse, like, you know, you should be dealing with it. Absolutely. Yeah. No time to take care of yourself. Yeah. 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 As a society, we're not talking about it. So why would health professionals be any different if we're people as well? So you guys are right. Stigma, which is huge. So I want you guys to think of it like I said, health professionals are people. So of all the reasons above mentioned, shame, not wanting to burden anybody, worrying that people will abandon you, or thinking that, oh, I'm a health professional, I should just deal with this myself. On top of all of that, we are struggling with the unique problems that health professionals struggle with. Long work hours, shift work, no sleep, things like that. I want to put something out there. When I was going through my school, I heard a few things that were kind of funny. And one was nurses eat their young. Who's heard that before? Who said that before? Who's done it? Yeah. See, and everybody's like, right. And is that not stigma as well, right? If you're going to do it to people, why don't we talk about it, right? We've all heard it. How come we're not talking about it, right? I had read a little story about somebody that posted for the Bell Let's Talk a campaign. And the story was a resident that actually went to, he was talking with a nurse on the unit, and this resident was like, oh yeah, it's been a really stressful day. And the nurse goes, you know what? I found a really cool show on Netflix. Like, maybe you should watch that, like, over the weekend. So he goes, you know what? I think it can take a few hours to do that this weekend. Maybe I'll just watch like the first episode. And then along comes the attending physician, and he goes, no, you'll be studying this weekend. I don't know how productive that is. And I don't know if you'll actually be studying this weekend by us saying things like that. But I've also heard this one. This one's my favorite. You guys in the back know, but it's, if you can't stand the heat, then get out of the kitchen. Like, what? Don't be in this profession if you can't handle it, which is kind of how we're treating it. That's also our culture, and that's part of the stigma. On top of like being worried about being judged about something, we're not talking about it. So let's go to patient X, right? This was the case study in the beginning. 26-year-old female with major depressive disorder. Why doesn't this person go get some help? Why not? All the same reasons. Thank you. To sum it up, all of those reasons. So I have another example for you because this is so important to me. How many of you guys have called in and said this? Oh, you know, I'm just calling in today because I've got debilitating depression. I can't do it. Just can't do it. See you maybe in a week. I'm sleeping. How many has made a call like that? What about, oh, I'm calling in today because I've got the flu. It's really bad. I don't want to be contagious. I've done that. How many of you have used the flu thing for a mental health day? Why are we doing that? You know, there's no shame in struggling with something that you need to call in for anyway. So we know that with depression, with anxiety, with bipolar, there are symptoms with that, meaning there's symptom management. There's a movement of treatment. You know, we're doing bad, we're doing good. It changes all the time. So we're not quite here yet where we can be like, not coming in. I've got depression. You know, we're not there yet, but my question is why not? So I have just showered you guys with doom and gloom of how broken our mental health is and all the stats and how everything's pitted against us. There's so much stigma. It's heavy. So I kind of want to ask, like, okay, what do we do now? It's broken. Okay, what can we do? I came across a really interesting paper by Dr. Patel. It's at the bottom there if you can see it. It is called Talking Sensibly About Depression. Interestingly enough, this actually applies, I think, to substance use as well. So he says that why are we waiting until people have a disorder to be really honing in and doing something about it? So he's like, we need to look at a continuum. So, okay, up here, wellness. We're starting with wellness. What does that mean? It's really trendy to be like, go get some meditation. I have a few apps for that. You know, it's really trendy. What does that actually mean though? You know, it's honestly, are you taking your lunch break? You know, are you getting enough sleep? When's the last time you had a day off? How many hours have you worked? You know, things like that. Have you seen your family, your kids? Oh, I have a kid. You know, like this is what's happening. Let's look at that. Let's look at like how we can keep people well. What keeps people well is different for everybody. You can get creative with that. For me, it's honestly, if I'm feeling down, I've got a power pose and it's this. It's Hulk. Okay. There's these little things that you do, right? Whatever works for you. Creative, right? Let's not be stuck in the wellness equals meditation and yoga. Let's not do that. So then there's distress, where you're starting to be like, oh, geez, today's been pretty stressful. I'm feeling it in my bones. You know, oh, it's wine o'clock when I get home. We're getting distressed, right? If that's happening all the time, right? Okay, now from distress, like that's not a point where you're actually having a full-blown disorder or having a problem where you need medical intervention for that or counseling or treatment, right? This is disorder where if you wait in the distress area for long enough, it becomes that. This is where your symptoms and things are starting to really affect your work. So it's changing your function. And then obviously after that, we see the refractory recurrent symptoms. So let's look at that with depression as well as substance use, right? So if we're looking at starting with wellness, we can all do something about that in whether you have depression or you're struggling with substance use disorder. If you're distressed, there are things to do. And I did just mention to you guys, like 1 in 5 Canadians struggle with mental illness or addiction. But guess what? Like 5 out of 5 people can help fix that. So I want us to take that attitude from here on out. Okay, so honestly, why don't we talk about it? So, okay, a few little things, because people always go, I'm in the back of their mind, they're always thinking, no, my unit is just going to always be like this. My manager is always, it's a pressure cooker where I work, this, that, and the other. There's nothing I can do about that. There's things out of my control. So I want to give you some ideas of thinking about that a little differently. So yes, we're busy. Yes, things might not change within the system we work in, but if you start talking to each other, that might. So instead of being like, if you do know someone who is struggling with substance use and they're kind of in recovery, instead of saying things like, oh, are you clean now? Why don't we say, how are you doing? Right? Little tiny things that we actually do for our patients and we don't do to each other. Let's move away from how are you? I mean, I started with that today, but how are you? I think that in my brain, I automatically go, oh, I'm good. I'm good. That's my response. And I'm expecting the same thing from you. So what if somebody goes, oh, I'm bad? Then I kind of go, wait, you're supposed to be good. Oh, geez, I'm not prepared for this, right? So instead of asking each other always, how are you? Why don't we go something specific? How are the kids? What did you bring for lunch? Like, how's lunch? Something more specific rather than like that, whatever it is that we've already calculated in our head to be, how are you? I'm good. That is my response, like a robot. There's ways to talk to people. So for example, if you do notice somebody in the distress kind of mode, they're looking really stressed out more than usual. And we know these things, we're observant people, right? Why don't you just go, what's happening? Even if you can't be like, oh, I'll take this off your plate, I'll do this. Like, that's not necessarily healthy, but it's just a matter of, I'm thinking about you, I see this, right? What are you gonna do today when you get home? Things like that. I'm curious to know what is going to happen when all these conversations change. So, revolutionary, life-changing idea, you guys. Just kidding, I psyched you, it's a different one. We do not have to settle on the way that it's been. Let me tell you something. I already know what it's like to work in this system. I don't like it, and neither should you. But we don't have to settle on it. Like, where did everybody kind of go, oh yeah, this is just the way it is. It's a stressful job, get out of the kitchen. It's, there's too much heat, get out. Why are we thinking that that's okay, right? So I have a few resources if you have no idea how to get started on it, if you don't want to settle. So a few things. One interesting tip, people are always going, okay, well, I don't know what to do if someone was to come to me and go, I'm struggling with depression. Funny, because if it's a patient, we're okay with it. We pull out the Hamilton D scale, we pull out everything, we pull out all of the major depressive disorder scales, and we have them circle things, and we know that this is like a robot kind of thing doing it. But when somebody else comes to you, anybody in your life, what can you say? My answer to that is in the title of my talk. It's, well, let's talk about it. That's a good place to start. Now, let's say that it is a lot. Where can you go? So employee wellness is one place. They're completely confidential. They do not talk to your employer if you do reach out for help. This is for health professionals. And if you guys are aware of the EFAP program, it's like Employee Family Services. I don't know. It's become employee wellness with a better logo. So, go on the website, see what they have. And what I like about this is that it's not just like, oh, you need counseling, go to this website. It's not. It's, they also offer free telephone conferences for your whole unit just to improve wellness. So they'll do that. They'll facilitate that and be like, okay, if morale is really low on your unit, why don't we look at it? What can we do? Small changes to make that better. Okay, next one is LEAP program. So this one is, I don't know if you guys have heard of it. How many nurses do I have here in the room today? Yeah, nurses. This is for you guys. Also, nursing students eligible for this program as well, totally free. And it is based for people that do struggle with substance use issues and even mental health issues. You can reach out to them. It is anonymous as well. Now, that being said, I actually talked to them because I was like, what do you guys do? So again, practicing what I preach, I'm talking to these people, and they told me that if a nurse were to remove him or herself from practice before you get a formal complaint, it doesn't actually go on your public record. So there's all these things that I didn't know. I thought the minute I go and I say, oh, I'm struggling with substances, it's going on my record, I'm losing my license, I'm getting put on a monitor program, stuff like that. You know what? Just talk to them, see what you can find out. Okay, for physicians, residents in the room, physicians, yes. Physician health program, I don't know if you've heard of it, 24/7 free confidential help. Interestingly enough, they have a free legal service branch that's also part of this. If you're wondering, if I were to report something or report my friend, what happens, you know? And you can have these conversations totally anonymously. So that's another resource for you. So I just want to check in and see if I'm doing it right. All right. There's one thing I wanted you guys to take away today. I don't know if you guys remember what it is. I'll give you a hint. And it's this. Health professionals are people. So I'd like you to just take that if you just came in for the food and you're falling asleep. That's it. That's all that I want you to take away. I want to go back to case study. Patient X, 26-year-old female, major depressive disorder. That person's me talking about it. I'm going to open up the Q&A here. I'm going to be taking questions. Please ask me. If you're online, please ask me. Yes. I've left my card on that table. You can pick it up. Talk to me. I don't care who you are. Talk to me. Again, 100% of you guys can get out there and change the statistics that I was telling you about. You know? And it's significant. Did you know in the United States, we lose 400 physicians a year to suicide? So think about your graduating class. That's everybody gone every year, every single year. That's not okay. That's not okay. So let's talk about it. Thank you.
Thanks so much, Maggie. I hope you all have some questions and discussion or comments. You can do that just by speaking or obviously using the app as well. And then we do have folks on the webinar, so we'll repeat questions if they're asked in any way. So yeah, turning it over.
I did get a question online or from somebody, I don't know. I wonder if the risk factors for substance use among health professionals, so long hours, shift work, lack of sleep, stress, also applies to those not working in acute care hospital settings. I'm going to break that up into two. Yes, it applies. There was a study that actually looked at nurses that worked in private clinics, in the community, in long-term care. It applied, from what I know. Now, nurses who work in the community, yes, are rates similar to people who don't do shift work. You know, I started off doing shift work, I did, but when my symptoms were really bad, I wasn't doing shift work. I was doing Monday to Friday. I was trying to do the right thing with my schedule. And I think, I mean, it's case by case basis, but again, the point is health professionals are people. And if 330 million people are struggling with depression, then why should shift work be the only thing that makes that difference, right? That's my answer to that. Okay, another question here. What's the suicide rate for dentists? I don't think it's good. I don't know, but BuzzFeed says it's not good. And also, actually, in the literature that I did go through, it was actually psychiatrists' highest rate of suicide. Some papers. I wonder why. Now, I could go on and on about this forever, but I think number one is denial. If you're seeing patients that are certified every day, you're going, I'm not being certified. Like this is not what I look like. I'm fine. You know, that's a big one. You know, just denial, not even knowing you have a problem. So I didn't know I had a problem until I stopped showering and didn't shower for a week. And my partner was like, something is wrong. Something's wrong. I didn't see it. I don't think a lot of people see it. And I've watched a lot of like testimonials and YouTube videos because I'm a millennial. And a lot of it was they didn't know that they had an issue at all until someone else was like, whoa, let's get some help because this is not normal. Yeah. Questions, discussion points, anything. Yes.
I'm a retired nurse. nurse now, but I'm just thinking over the many years that I worked, healthcare has certainly changed, and I'm just wondering about the relationship. Certainly, we're busy every day, and we're helping, or we're doing what needs to get done. But I'm wondering if there's a bit of a disconnect between what we're actually doing and what we're observing as the outcome. Like, are we really helping, or are we caught up in this endless cycle of
Yeah.
desperation?
So the question is, are we really helping, or are we just sort of, we keep trucking along because we don't have time to think about it maybe? Or I have a interesting kind of scenario that I looked at. In 2015, there's 35 United States that were asking on the registration when you get your license as a physician every year, have you been diagnosed with a mental health disorder in your lifetime? So if you were 8 years old and you had counseling at 8 years old, technically, or if you had some sort of thing where you were, I don't know, diagnosed with ADHD or something in your youth, technically you had to report that. And so the way that relates to your question for me is, I think we perpetuate the problem. The nurses eat their young. We're asking people, do you have a mental health disorder on the actual registration? North Carolina, though, shout out to North Carolina, they actually removed that recently and totally took the question out because they found that 22 people have actually reported, yes, I do have a mental illness. And they revoked licenses for 0 of them. So then it was like, why ask the question if we're not, there's not really, and that's the thinking, obviously there is a vested interest in protecting the public, which is why I think they were asking those questions. But we have to take a look and see, is the data and all of that suggesting that we do something like that? Or is that something that might actually be infringing on your rights as a person? Because in the Disabilities Act in the States, it states that you cannot discriminate against somebody for having a disability or illness. So why are you asking, So that's my kind of response. I think we're perpetuating the problem right now, but if we're perpetuating, why can't we be doing the opposite? That's my question to you. Eric. Thanks for coming.
First of all, thank you for the presentation. I would like to say for those that don't know Maggie, that she is wonderful. I am fortunate enough to be on a WhatsApp group with the other nursing fellows in Maggie, and she very much practices what she preaches. So this is a great presentation. You mentioned a little bit about the culture and how this idea of when you're young or having to pay your dues and those types of things can be negative. Do you see any positive things or things that are going on in the culture of healthcare that are helping to promote, better mental health and substance use? For myself, I think about the private sector where there's a lot often of team building and having opportunities to create community with the people you work with outside of your workspace. Obviously, I think funding is a big byproduct of that being able to happen. But I just wonder if there are things that you see or initiatives going on, or even some of our organizations like BCNU or elsewhere that are trying to promote that type of thing.
So question is, am I seeing anything that's kind of promoting it instead of like our culture ripping it down and for what we're trying to build? The answer is yeah, I am. And where I'm seeing it is, the BCNU, I don't know if you nurses got a email recently, and it was surveys about psychological health and stuff like that. And you kind of filled out, how often do you feel stressed? And like all of this, they're looking into that, which is interesting for me. I like that we're gathering data. And I think this is what we've got. The best thing going for us is that we have knowledge of depression and substance use. We're health professionals. We have knowledge. We know what depression looks like, just not in ourselves. But if we talk to each other about it, I think that can change things. I think funding's a big one. But I think the more we're noisy about it, the more somebody might want to come and like grease up that wheel for us. So that's why I'm like, it starts with talking. I should look into it though, to see if there's more happening where we're doing more for our culture. And again, remember, you don't have to be up here doing a talk to make that culture any different on your unit, you know? It could just be like, hey, attending physicians, stop it. Netflix is a need. We need that. Go away. Jen? Oh, yeah?
Well, first of all, thank you so much for this awesome talk. I really love that you use this app, and it's really refreshing the way that you.
Thank you.
And I really, my takeaway is when you said that you want to five vessels experience issues, and that 5 out of 5 vessels can start to do changes, and then you've actually given us a tool that we can start right away with language, and I think really what will take us even a step further is that we share this with you. And I think that's awesome.
Yeah, just in case you didn't get it, it's like, come on, we're people.
Yeah.
Thank you.
And then we talked a little about depression, but there's also anxiety.
Yep. There's bipolar, there's schizophrenia, there's, oh my gosh, everything else that everybody else is struggling with.
But I want to say that I never really saw myself as experiencing anxiety until my lectureship in nursing school. And I thought, why am I not doing going out and doing social things? Why am I scared? I don't even know what I'm scared of, but I was scared. And then I realized for the first time ever, oh, how is it? I didn't know. It was situational, but yeah, it was just really interesting. So I just wanted to say that there's a lot of anxiety as well, depression. And then final thing, that I want to say, yeah, is that when I work with people who use substances, as some of you know, and I always feel like some of the really important things in recovery are that sense of purpose and that sense of belonging and meaning in life. And so for me, actually, nursing brings me a lot of that too. I take a lot of pride in what I do, like a lot of us, I'm sure, people as well. So as much as in our culture there is, a lot of pressure and burdens and this kind of thing, there's also, I'm sure we all know that, I talk about how there's a lot of reward.
Yeah.
And that when we're changing the culture of talking about these things, that maybe management, the bigger organizational picture of people involved in that could look at recognizing the good work that we do. Well, it's a way to
So Jen, really optimistic message for people online that are listening. How many of you guys have heard or think, I'm a nurse, but I hate my job? How does that work? Or I'm a nurse and I love nursing, but I don't like my job. It's kind of weird because, a lot of our work is admin work, things like that. But you're right. There's a lot of meaning behind what we do. And the funny thing is it works for us and against us. So what I mean by that is, what makes a good nurse or a good doctor? Anybody got any ideas? What makes a good nurse or doctor? Compassion. Yes. What else? Commitment. Yeah. Listening, being a good listener. And guess what? Good boundaries. But guess what? Good boundaries equals sometimes dissociation and depersonalization, which means that's why it's so hard for us to know when something's going on with us. Because to be a good nurse and a good doctor, you have to have these skills. So there's that. But at the same time, we got a lot going for us. We're really talented folk, if I say so myself. I have a few questions here. Yeah, I will get to the online ones in a second. I left a lot of time for us to talk. Elspeth.
I echo it there. And I'm always curious why people get into their profession. And I remember in our first 2 weeks of our fellowship, someone said something about the fact that healthcare professionals have higher ACEs scores. And why do we work in this trauma-informed environment and yet we don't treat our healthcare professionals from a trauma-informed lens? And I don't know if you saw anything about the fact that that's true, that there is the higher adverse childhood experiences, and maybe that's the reason why people go on health.
The question is, did I see any literature on kind of health professionals having higher ACEs, which is adverse childhood events? I didn't look into that, to be honest with you. I'm really curious to know, but I wouldn't be surprised. I mean, I think it makes you really experienced if you have experiences that your patients or clients are dealing with too. I think it makes you better. Yeah, it's everything seems like a double-edged sword. To make you good, you need this, but also it's bad when we're looking at ourselves. Yeah, the good thing is that I didn't see very many studies that were like social workers or nurses or professionals they're really bad at their job. Didn't really see much of that. So we got that going for us. We just got to focus on the other front, which is us. And yeah, I got quite a few questions. Yes, in the back with the black hoodie.
You're talking about mental illness among healthcare professionals, and you mentioned depression and anxiety. And I'm just wondering, in terms of that, the research, are there any other types of mental illness that are common as well? Like bipolar or I'm just curious.
Yeah, so question was, did I see any other statistics? I covered kind of depression and anxiety, and if there's any difference in health professionals in regards to, say, bipolar or schizophrenia or, anything like that. I didn't honestly really look into that much because I focus on depression in this talk here, but it seems that depression and anxiety are hand in hand. And here's something that I kind of want to repeat again, it's that all of the literature are our best guess. So what does that mean? It means that there's already stigma talking about this, and a lot of the studies that I looked at were surveys that were nationwide or just self-reporting your symptoms. And if there's already a stigma, I bet you there's lots of people not reporting. So the number 1 in 5 Canadians might actually be higher, because first of all, you need to really know yourself to answer the questions properly. And a lot of people are in denial if they are struggling with something. So I think maybe that's why I couldn't find very much when I was looking. Yeah, but thank you. I will actually look into that. It's interesting. Okay. Yes.
I just want to say, like, I really appreciate that you're talking about this because it's super important. And one of the things that really resonated with me was this whole part about if you can't handle the heat, you have to get out of the kitchen. Because I find a lot of the times, especially I'm a psych nursing student, and I find that a lot of the times I'm hearing that you'll get used to what you're doing, but that makes no sense to me because you don't want to get used to seeing people in pain because then you won't learn to recognize the pain. And that's just my own thinking, and it's really refreshing to hear that you're doing a presentation and really kind of picking it all apart and showing it to people who need to hear it.
Thank you. Thank you so much. That means a lot. Comments about in nursing school, you'll get used to it. I'll tell you a story actually, really quickly. I almost flunked out of my first year of nursing. I actually left and then my mom was like, all right. I talked to this lady right here in the middle, Buena Manantag, great support. She said, take your time with it. And then I talked to nurses who were doing the same thing. And I was like, whoa, that's what the job looks like? I don't want to do that. I'm not built for this. So I left nursing. I went to do philosophy. I went to do, sociology. I did I don't know what to do. And honestly with you, I could not see myself doing anything else. And I really struggled with being like, how do I get into this in which I'm supposed to just accept that this is the work condition? But I just can't get over it. And then it got to a point where, Mom, if you're listening, I couldn't afford another year of school. I had to finish that thing. And I will tell you, I cried every day on the surgery unit, on the medicine unit, ENT, baby unit. It doesn't matter. I cried every single day. And when I finally picked addictions, people were like, why do you want to work in addictions? You want to work with addicts, with those people? And I was like, I guess so. I mean, in my head, they're just people. So I landed. And I will say to you, don't settle. If you don't like that unit you're working on, heck with it, do something else, right? Find that thing. And the great thing about nursing, the only thing I know, is that it's very broad. You can do a lot of things, right? You can do this thing, you know, stuff like that. I never dreamed that I'd be talking to you guys about this because I'm 28. How many of you guys are older than me? Or, yeah. Look, all these people have more experience than me. So why should I be doing this? And what I want you to take from that, being a nursing student, is like, doesn't matter where you are at, you have something to give, and do not ever settle, because settling sucks. Okay, right in the middle.
Have you ever tackled the whole moral distress? Because I work in a drop-down clinic, and I see a lot. I work in downtown side, and I see a lot of people who are searching for help around the street, and we have wait lists, like more than 400 wait lists. And my moral distress is we cannot take them. And I know that they're gonna die soon because there's a risk of opioid use.
It's huge, yeah, the opioid epidemic.
Illicit opioids. So my distress is like, why can't we not make another clinic to help them? So that's bothering me every time I do it.
Question is, why can't we save the world? Really good question. I haven't figured it out yet, so if you do, let me know. Yeah, I get that too. If you're wondering about the moral distress, I don't have an answer for you. I wish we had all the funding in the world. I wish I wish I didn't have a job. You know why? Because the day that there's no addiction, my job's gone. I'd like that. I do. And we want to save the world, but who's saying that you're not doing that in your own little space? What we need is like everybody to come together and be like, this is a problem. Let's put funding in it. Let's get behind it. You know, let's stop looking at stats only when they affect white people in the suburbs, right? Things like that. I don't know if that's a little harsh, but let's look at things differently. Let's use technology. You know what's interesting? I read an article this morning. There's a book out there, and it's about AI in medicine. And in North America, they're developing an algorithm that can go through people's Instagram posts and see if they could diagnose depression from the filters they use, from the language, from the content. It's 2020. Let's think about things differently. Yeah, I mean,